Good day. I'm Morton Kern. I'm the Chief of Medicine at the VA in Long Beach, California, and a current interventional cardiologist as well. And I'm going to talk to you today on the basics of mechanical circulatory support, the hemodynamic underpinnings of why we should use these devices and how they differ. My disclosures are shown here. I speak for companies that make physiologically measuring equipment and companies that develop these techniques. We're going to start with the fundamentals of cardiogenic shock. And this is a condition that is critical in terms of interrupting these downward spirals to prevent death of our patients. And one of the arms of treatment will be the implementation of mechanical circulatory support devices. So let's just start at the top. Patient has a myocardial infarction. It's significant to cause left ventricular systolic and diastolic dysfunction. The first grouping of parameters that we look at involving systolic dysfunction on the way into critical shock begins with reduction in cardiac output and stroke volume. These produce hypotension. Hypotension produces peripheral perfusion deficit and coronary perfusion deficits, and the body responds by attempting to produce and sustain blood pressure through vasoconstriction and fluid retention. At the same time these processes are going on, there is a systemic inflammatory response characterized on the left around the blue circle there, in which nitric oxide synthetase is impaired. There's an increase in the nitrates, TNF alpha, and a number of other factors which act to lower systemic vascular resistance, the opposite of what we want to do to preserve blood pressure. The pro-inflammatory moieties circulate, catecholamine sensitivity is decreased, and further contractility is decreased. And that brings us over to the pharmacologic treatment shown there in the upper left, but it further adds to our needs to provide volume resuscitation, inotropic support, vasopressors, and often we implement mechanical reperfusion and support of the circulation perhaps too late in this process. And hemodynamic support will address left ventricular end diastolic pressure elevation and hence pulmonary edema. It will address, we hope, coronary perfusion and reduce left ventricular demand for blood, thus reducing ischemia. And it should, on reperfusion, reduce the progressive cardiac dysfunction that may be occurring through poor circulation, peripheral constriction, lactate elevation, and systemic inflammatory activation. So there are benefits on multiple levels rather than just increasing blood pressure. Now, as shock progresses, it moves from strictly a hemodynamic derangement into a hemometabolic derangement. And it's a matter of timing and intensity. And if we look from left to right, and the top boxes characterize the different issues are attacking our patient over time in this relatively acute setting. Circulatory support and systemic perfusion at the top left. This manifests with a decrease in arterial pressure and elevation of lactate creatinine. And it's principally a hemodynamic problem, and our mechanism to address it is hemodynamic support and circulatory support and ventilatory support. Second box from the left would be ventricular support with ventricular unloading, both right and left, depending on the infarct. These are manifested by increasing end systolic volumes, decreasing end systolic pressures, and aortic pulse pressure. There may be ventricular tachycardia superimposed because of poor ventricular function, and we'll see markers of congestion like BNP increase. Further, and in concert with the other two, would be coronary perfusion deficits. And again, this is often characterized hemodynamically by a reduction in the difference between mean arterial pressure and left ventricular end diastolic pressure. The smaller the difference, the worse the perfusion gradient. ST changes, troponin elevation, myocardial CKMB are all markers of the impairment of coronary perfusion with myocardial ischemia. And then ultimately, the patient, if he cannot be stabilized, will develop renal and hepatic impairment. These would manifest again with high right-sided pressures and elevated creatinine, liver functions, and a coagulopathy. Ultimately, in many cases, this heralds the end of our patient's survival. And again, we look to the unloading of the ventricle and support of perfusion through mechanical circulatory devices. Now, we have several devices available to us, and I've shown them here to you from sort of weakest powerful, the least powerful to the most powerful. And these would include the intra-aortic balloon pump on the left, the Impella, the tandem heart, and the veno-arterial ECMO pump system. And this may or may not include an oxygenator. Now, if you look on the vertical columns, these are functions of cardiac flow, the mechanism by which the flow is supported, the implant duration, which is possible, the size of the sheaths, which is often a determinant of which device to use, and the necessity for cardiac synchrony. And we're not going to spend a lot of time with each one, but I will show the metrics of pressure volume loops generated by these devices to help us select or at least understand what their impact may be on our shock patient. Here is a summary of the hemodynamics by each device. So if we look at afterload reduction, we see that this is decreased with the intra-aortic balloon pump and Impella, and unfortunately markedly increased. Afterload is increased with the VA ECMO because it's returning blood against a closed aortic valve. Mean arterial pressure is elevated by all devices, more so with the more powerful hemodynamic devices. The same can be said for cardiac flow and power. Left ventricular end diastolic pressure is reduced with the balloon pump, but markedly reduced with Impella and tandem heart, and marginally reduced by VA ECMO. The wedge pressure parallels the LV-EDP, and we see that coronary perfusion has the potential to be increased by both balloon pump and the Impella, and less so by tandem heart and ECMO. Now, recall that the severity of the stenosis dictates whether external perfusion can push blood through that stenosis. So severe lesions will not be perfused by almost any device. Myocardial oxygen demand is important, and of the devices that reduce it, the Impella seems to have the most potent ability to reduce oxygen demand of the myocardium. So keep that in mind as we look at device selection coming up in just a moment. Here is a summary from O'Neill's paper on the anticipated cardiac output we might like to see with each device. Again, in order of what we just saw, the balloon pump is least powerful and the VA ECMO is most powerful. There is overlap with the Impella CP and the tandem heart and the Impella 5 with the VA ECMO. So these are potential alternatives of increased cardiac output when needed. Okay, let's start briefly with the hemodynamics of AMI and shock and the pressure volume loop, which we'll use to gauge the potency of the other devices. The pressure volume loop begins at the end of diastole, or at the end point where the end diastolic pressure volume relationship increases along the isovolumetric contraction to the ejection point where the aortic valve opens. Across the loop is the stroke volume during ejection, ending at the end systolic pressure volume relationship point of intersection. And then it falls with isovolumetric relaxation down and begins filling again along the end diastolic pressure volume line. Now, a line that connects the multiple loops at end systolic determines the contractility metric. And the line that connects the end diastolic pressure volume relationship to the end systolic relationship, the slope of that line tells us about total peripheral resistance. And if we look across at myocardial infarction, we can see that the infarcted myocardium pressure volume loop is shifted upward and to the right, decreasing contractility, decreasing stroke volume, increasing LV-EDP, and diastolic pressure volume relationship. Further to the right on this graph, you see when you really get into shock, your output is way down, contractility is way down, volume of ejection is smaller, and your end diastolic volume is very high, and you are congested. So these describe the phenomenon, both of infarction without shock and then ultimately infarction with shock. Now, let's look at the devices and their impact on the pressure volume loops. Before we do that, I want to just identify that myocardial energetics and myocardial oxygen consumption is a function of the pressure volume area. Now, what does that mean? In the upper left, you see the pressure volume loop with stroke work. That is all the energy it takes to create the function heart contracting and relaxing and contracting and relaxing. But in addition, there is potential energy of the area depicted by the end systolic pressure volume relationship here. And as that shifts, or as the curve moves, the total area of both potential energy and stroke work energy talk to us about what this heart's myocardial oxygen consumption is doing. So then we would like to see not only pressure volume loops that are effective in increasing pressure and stroke volume as an output as needed, but also in reducing total myocardial oxygen consumption or total area. Now let's start with impeller pressure volume loop. Take a look here in the lower left. We see that the control loop is blue, and then as the impella is turned on and ramps up, the device is continuously taking blood from the LV, shipping it into the aorta, and creating this sloped or triangular shaped pressure volume loop. And the pressure volume area for that pressure volume loop is reduced, meaning it reduces myocardial oxygen consumption. Wonderful. Let's take a look at ECMO now. That's the middle panel. And the control loop is the big blue one. And then as the ECMO takes blood from the venous system and then puts it back in the femoral artery, the work of the heart is markedly diminished. The stroke work is really significantly reduced. That's evident by the red box, this very narrow red box. And so the stroke volume work and potential energy at the beginning is large. And when you turn on ECMO, it gets either the same or it gets larger. And so it does not reduce myocardial work. Again, it pumps blood against that closed aortic valve, and unless vented, can be problematic. And lastly, if we look at the work of the tandem heart, again, start with the blue loop. It's big and wide. Stroke volume is struggling. Then as you turn on the tandem heart, it takes blood from the left atrium, delivers it through the pump to the to the femoral artery. And thus it, in the same manner as ECMO, produces a taller and narrower pressure volume loop and does not reduce the pressure volume area. This becomes more important when we look at selection of devices again. So again, we talked just briefly, this is a quick summary of effects. The intra-aortic balloon pump on the left has a modest impact on reducing resistance. That's E and A lines here. It will reduce, can reduce a little bit end diastolic pressure and volume. The impella and tandem heart, again, shift the curve downward and left. Stroke volume is smaller, but it is picked up by the device. So the change in stroke volume is intrinsic plus the device. And then finally on the right is the veno-arterial ECMO, making this taller, narrower curve where the pump does most of the work and doesn't do much. Now, cardiac power output is a function of the heart's ability to pump, and we can augment power output by devices, but it's calculated as mean arterial pressure times cardiac output divided by a correction factor of 451. If anybody's listening to this and knows how we got 451, please tell Dr. Burkhart and myself because we can't find it. But nonetheless, when your cardiac power output is less than 6, and certainly less than 8, your survival is reduced significantly such that your mortality rate is 30% or greater for a cardiac power output of less than 0.8. So it's important to think of this power output in terms of cardiac output and pressure because it does influence survival. Now, as we as we talked about the functions of these different devices in terms of hemodynamic support based on cardiac power output and myocardial protection based on the pressure volume area or reduction in oxygen consumption, you can see significant differences both in the direction and magnitude of the effect. So inotropes and inotropes with balloon pump have very modest effect on cardiac power and a negative effect on pressure volume area. Tandem heart, much more powerful, but having a modest or neutral effect on pressure volume area. ECMO, even more powerful, but also has a higher cost of use. The Impellas, both 2, 5, and 5, have significant increases in cardiac power output and significant degrees of myocardial protection, making them, in my view, a highly favorable device and a good option for first selection of these critically ill patients. Now let's just shift gears. You have a 71-year-old man. He has chest pain, lightheadedness, pallor, sweating. He has this EKG showing a significant inferior acute myocardial infarction. He receives fluids and dopamine because he's hypotensive with blood pressures in the 70s, heart rate's only 68. And now we have to manage him. Here's what his coronary artery looks like, total right coronary occlusion, no mystery. Do we support his shock with more drugs? Do we support his shock with balloon pump? How about LVAD or tandem or whatever? So here's what this gentleman received to support his critical RV infarction. He received the RP Impella. And this brings blood from the inferior vena cava and right atrium up past the RV, which is not functioning, into the RV outflow into the pulmonary artery. And this is a really important device for this relatively uncommon condition. Now, we have not only Impella RP, we have a tandem heart for the right RVAD, another external centripetal pump implanted from above, and a VA ECMO. And they all do similar things, but I think the RP Impella is highly effective, relatively uncomplicated to use. Now, what's most interesting is we rarely get to see RV pressure volume loops, and compliments of Dr. Kapoor from his paper in 2017, we get to compare the LV pressure volume loop above at baseline and during Impella, and on the same time, the RV pressure volume loop on the bottom. Notice the shape of the RV pressure volume loop. It's wide and ovoid as opposed to vertical and almost rectangular. And when you implement Impella, that is RA to PA pressures, you create this vertical and upright rectangular pressure volume loop. And at the same time, you increase PA pressure and decrease RA pressure. So it is effective hemodynamically, and it is effective clinically. Okay, in wrapping up our discussions, I want us to be thinking about the implementation of support early. And from Doug Drachman, and then from an editor's page we wrote about a couple of years ago, I think that we should consider for shock patients door to unloading time rather than door to balloon time. And there's some data to support that from Flaherty et al. And colleagues in a meta-analysis showing that early Impella or early hemodynamic support with this device improves survival in the cardiogenic shock patients. Lastly, the use of Impella, because it has had some limitations early in its release, now has expanded FDA indications, which include use in mild, moderately reduced ejection fraction patients during high-risk PCI, as well as use in cardiogenic shock, including those patients who have cardiomyopathy, peripartum, or other myocarditis for the support of temporary cardiac function in these clinical settings. Lastly, I think there's been a lot of progress made for the characterization of shock patients for future study, and it's important that we study similar types of patients to tell us whether certain devices work better than other devices. We can never come to those conclusions when we have a mixed collection of shock patients, some of whom will never survive, some of whom will always survive. And this categorization from the SCI expert consensus of the classification of cardiogenic shock was a big advance. And in brief review, we should be studying patients of similar classifications when possible to make our understanding of outcomes even better. The details of this are available in Cath and CV Intervention this last year. I think this is a wonderful paper. So I'm going to say, in conclusion, we have covered a lot of the ground of the hemodynamics of shock. And we know that shock activates compensatory mechanisms to preserve perfusion. We know that the pressure volume loops describe cardiac responses for these acute conditions, both myocardial infarction and shock, and that using pressure volume loops and computing pressure volume areas, we can determine those devices providing best myocardial oxygen consumption indices and differentiate devices one among another for this particular effect that we'd like to achieve. And lastly, survival in shock, I think, is related to the early implementation of mechanical support to improve systemic and coronary perfusion and thus avoid the multifactorial mechanisms of the death spiral in these unfortunate patients. I'm going to say thank you very much for your attention and look forward to seeing you at one of our future meetings.